Hey guys, Dr. Priya here. Welcome to a super quick, I hope, crash course on vision, because there is no way you're going to be able to understand anything about examining the eye unless you have some bare basics of understanding how the eye works. So here we go. Okay, so hopefully you guys recognize that this is the eye. That's a really good start. And if you actually take the eye and take a cross section of it, it will look a lot like this. And what I want you guys to consider right now is when you're going to do a clinical examination of the eye, you're going to start by looking at the patient from the outside. This is not an autopsy, so you're not going to have the benefit of being able to take your patient and chop the eye open to have a look. So now what you want to think about is when you look at your patient, from this picture, what can you see from the outside? And what is it that you're going to have to use equipment to see? What can you see? What can you evaluate? What do you need to infer? What other kinds of tests do you need to do? Okay, so when you look at the eye from the outside, basically this is what you can see. You can see the eyelid, you can see the iris, and you can see the pupil. Okay, and if you look at the eye in cross section, what you're going to be able to appreciate is that over here, there is a covering on the outside of the eye, which is your cornea, which is what you can see, and the cornea is crystal clear to allow light to enter the eye. And over here, this little blue colored ring here is the iris, which correlates to the iris you see there, and that is actually a ring which contains smooth muscle and can actually dilate or constrict. And this black hole, or the pupil, is literally just that. It is a hole in the middle of the iris, and you can control the size of the pupil by virtue of dilating or contracting the iris, and that is controlled by your cranial nerve 3, and that carries in sympathetic fibers, and there are also parasympathetic fibers which come into the ciliary nerve, which you will learn more about when you do the eye. Okay, but for now, just know that there are different nerves that bring in parasympathetic and sympathetic fibers, which then control the dilation and contraction of the pupil. So when you assess pupillary size and whether the pupil can constrict or react, this is essentially what you are assessing. And you actually need to constrict or dilate the pupil in order to control the amount of light that enters the eye. Okay, behind the eye you have the lens, and the lens again needs to be really clear so that light can actually enter the eye. Behind that you have the vitreous humor, which is again a crystal clear fluid, and right at the back of the eye you have something called the retina, and this is a very important part of the eye, because this is the entire layer that contains special cells called photoreceptors. Photo for light, receptor being a receptor. So this is actually where you capture light rays and you convert the light rays to a neural signal, and those neural signals will then travel via the optic nerve to your brain. Okay, so if you can see this thing from the outside, what can you see on the inside? Well, you can use something called an ophthalmoscope, which is this gadget here which you're going to play with during clinical skills, and this will allow you to actually look into the eye via the pupil, and this is what you will see. You will see the retina, and you will see the optic disc, and you will see this red spot called the fovea, and the fovea represents the point where you see the most clearly. The optic disc represents the spot where the optic nerve actually leaves the eye and goes back towards the brain. And the very interesting thing about the optic disc is because it is just a nerve, there are no photoreceptors over it. So you can't actually capture light at that spot. And that's going to be significant because that is what we call the blind spot, and we'll talk about that soon. So that's the whole thing about the eye, and that's basically what you're going to see if you use an ophthalmoscope. We will talk about this in a lot more detail in the lectures that you're going to do in semester 2. This is just a super quick crash course so that you can make some sense of the clinical skills session. Okay, so the whole thing about the eye is basically to allow us to see. And how do we actually see? We see when light enters the eye and gets focused by all the various structures of the eye, and then that focused image actually lands on your retina, and your retina converts that into a neural signal, and that actually travels to your brain via the optic nerve. And once it actually gets that neural signal travels via your optic nerve, it will travel via a complex series of pathways to reach your brain. And once it reaches your brain, that is when it starts to be actually processed to be meaningful. And from your visual cortex at the occipital lobe, which is here, it will also move to your language centers and your memory centers to allow you to actually identify this as something specific. Okay, so it's a pretty complex process. So in order for us to see clearly, that light from the outside world has to be focused sharply on the retina. So you can see in normal vision, it focuses to a point bang on the retina. If you have myopia, which is short-sightedness, that point will focus in front of the retina rather than on it. If you have long-sightedness or hypermetropia or hyperopia, it focuses behind the retina. And if you have astigmatism, your cornea, that crystal clear layer in front of the eye, is actually uneven. So the light focuses in all these random pinpoints of light, so you see fuzzy. You don't see clear and your eye gets tired very easily. And this is just a representation of what people with all these different sorts of refractive errors might see. And in order to fix refractive errors, basically you can wear glasses, because the glasses will help you to adjust how you see. And I know this is a very old school Superman, but Christopher Reeve is still my favorite Superman. Okay, so if you look at this image, this shows you how you can correct refractive errors using lenses. This gives you an idea that you can actually use concave or convex lenses to alter the degree to which the light bends, so that you can then bring that light to the correct focus on your retina. Okay, so how do you assess visual acuity? Briefly, during a clinical encounter without complex tools, you use a Snelling chart. And you will see this in the classroom, and we will show you how to use it appropriately. But essentially, your patient is going to be 6 meters or 20 feet away from the chart, and you're going to ask them to read down the chart until you get to the last line that they can see clearly, and then you will use that to express the degree of their visual acuity. What happens if your patient can't even read that big fat E on top of the chart? Then you have to resort to different ways of assessing the visual acuity. Can they count your fingers? How many fingers is this? 2, 3, 4, Or can you wave your hand in front of the eye? Can they see that there's movement? If they can't even see movement, shine a light in their eyes, see if they have light perception. If they can't even see light perception, they are essentially, to all intents and purposes, blind. Okay, so now the next bit of your eye is that your eyes can move, and I'm sure you know that if you look around you can see your eyes move. So how do your eyes move? Your eyes can move because they have these things called extraocular muscles, and there are actually 6 different extraocular muscles surrounding the eyeball, and they all control the movement of the eye in different directions. You will again do this in a lot more detail in SEM 2. What I just want to highlight is that these are the directions in which the different muscles move the eye. The superior rectus, inferior oblique, medial rectus, superior oblique, inferior rectus, and lateral rectus. So they all move the eye in different directions as these arrows indicate. And they are all controlled by different cranial nerves. Most of them are actually controlled by cranial nerve 3, but the superior oblique is controlled by cranial nerve 4, and the lateral rectus is controlled by cranial nerve 6. So this is the usual mnemonic to remember it, SO4, LR6, and everything else is controlled by cranial nerve 3. And what you can also see is that in the eye, if you can imagine, if you're looking towards the left, your right eye will actually move towards the nose, and your left eye will actually move outwards temporally. So different muscles actually being activated in like this. In your right eye, if you're looking that way, it would be your medial rectus, whereas in your left eye, it would be your lateral rectus. So different muscles have to be activated in synchrony, and there's a very interesting mechanism by which your brain coordinates this, which again we will do in semester 2. But the whole point of why your eyes have to move in synchrony is to allow you to be able to see clearly using your binocular vision. So this image over here is basically what I want to highlight to you, which is these are your eyes, and your eyes are basically receiving light from your entire visual field around you. And if you imagine this visual field like here, this area right in the middle here, the binocular visual field represents the part of the visual field in front of you where the light from that part of the visual field enters both your eyes. And the advantage of binocular vision is that because you're receiving light from the same area into both your eyes, the angle of the light that enters each eye will be slightly different. But your eye is programmed to know that the light that comes from that specific area that reaches both your eyes is actually coming from the same point in your environment. And that lets you process with greater depth perception, which allows you to have a much better view of the world. So if you imagine point B over here, and you look and see this point B traces its way here, and it goes to this point on your left eye, and it goes to that point on your right eye, so there and there, and your eye codes that those 2 points are reading from this point in the environment. So what happens if one eye isn't moving in synchrony? Then the light is going to fall on the wrong part of the retina, and you're going to get mixed up signals going to your brain, and that's what you're going to call binocular vision dysfunction. And your brain is going to get confused, and you're going to have something called diplopia. which is when you actually have double vision. Okay, so how do you actually assess this grossly clinically? You do this. You sit in front of your patient and you move your hand and you ask them to keep their head still and follow your eye in a big H-shaped motion. And by doing that, you will assess all these different movements and you will be able to assess all those movements of all the 6 extraocular muscles. And if your patient has diplopia, then you know that probably one of the eyes, one of the muscles is not moving correctly. And by assessing what you see and trying to figure out what sort of diplopia the patient has, you can actually work out which muscle is most likely to be giving trouble, which muscle or muscles, and then maybe you can figure out where the problem lies. Okay, then one other thing you're going to assess are the visual fields. So the visual field, again, is the whole thing you see in front of you. And what we mentioned is that the light from different portions of the visual field hits at different portions of your retina. And once that information from different parts of your retina actually enters your optic nerve, it also goes in very specific pathways, so that information from a specific area follows a specific pathway and just a specific part of your brain that your brain can process accurately where the information is coming from. And there is a very interesting pathway by which your brain does this. And again, if you remember binocular vision, the brain actually needs to compare information from the right eye and the left eye and unite them to be able to compare and contrast it, to be able to make sense of your environment in a greater depth perception. So if you look at this, you can see over here in your visual field, the right side of your visual field is represented in red and the left side is represented in blue. And what you're going to see is that in the eye, it's going to be represented slightly differently, because the right side, which is red, in this eye, it becomes your temporal nasal field, whereas over here, it becomes your nasal field, and vice versa for the left visual field. And then what you're going to again see is that in order to get depth perception, this red colored visual field must all go to the same side of the brain. So you can see that these red fibers that enter from your optic disc and then finally reach your brain, all the red ones go to one side, all the blue ones go to one side. So if you look at this red one, what you're going to see is that from the nasal field, it actually has to cross over from the right eye to the left side of the brain. And this structure, at this point where it crosses, this is what you call the optic chiasm. And right above the optic chiasm sits the gland called the pituitary gland. So you can see that over on the left side of the field, also from the nasal field, it has to crisscross over to reach the right side of the brain, and then it will eventually reach your visual cortex. So you will learn this in a lot more detail again in Sem 2, but the typical patterns we want you to recognize are that if you compress the optic chiasm, classically because it's a pituitary tumor, then what you're going to lose is both the nasal fields of your retina, which if you trace back are actually the temporal visual fields of your eye. So what you would have is this, which is something that you call bitemporal hemianopia. Okay, so you can have a look at the images, but mainly the one that is of most clinical relevance that we usually keep asking you guys about is this one. Okay, and how do you assess this clinically? Like this. You sit about an arm's length from your patient, and you hold your hands out and you kind of test how much they can see in the different visual fields. And we'll show you how to do this in the class. Okay, and then the one other thing that we want you to see is the blind spot. And we mentioned earlier that the blind spot is actually the area on the retina where the optic nerve actually leaves the eye. So it is a blind spot because light that falls on that area doesn't get converted to a neural impulse, because that's where the optic nerve is, so there are no photoreceptors there. You can't convert the light to a neural impulse. But if you look at this, what you can see again is that the light that enters your eye, center of vision, hits at the macula, the fovea, point of maximum visual acuity, whereas some light actually hits on the blind spot, because light that enters is going to hit all over the retina, and there is some parts of it that are hitting your blind spot and therefore are not being converted to neural signals and therefore not reaching your brain. So there is an area where you can actually try to evaluate, and you use a little red hat pin, which I'm going to show you. So you cover one eye and you're going to move that hat pin slowly straight across the eye, and you're going to find that there is one point where that red hat pin disappears, and that is your blind spot. And we'll show you how you actually do that in the class, and how do you actually figure out if your patient's blind spot is normal. You're going to compare it to your own blind spot. So you and your patient must be sitting directly across from each other, the red hairpin should be directly in between the two of you, and it should disappear and reappear at the same point for you both, so that you can get this idea that your patient's blind spot size approximately matches yours. So if yours is normal, then your patient is pretty much normal. There are, of course, much more sophisticated pieces of equipment available for formally mapping the visual field in a blind spot, but this is what you can do in the clinic setting, and this is what we're going to show you in clinical skills. Okay, so that's all I'm going to show you. So it's already been about 15 minutes, and I think that's enough for this. So just have a look at this and have fun in the class. Take care, guys.